Assalamu alaikum, the clinical day. Mr. Sami Jones, 35 years old, with complaint headache. Please take history, examine your patient, and address his concern.
Hello, good morning.
Good morning, doctor.
Can I confirm you are Mr. Sami, 35 years old?
Yes, doctor. I am Mr. Sami.
Nice to meet you.
Nice to meet you, doctor.
We are here today to discuss your medical condition and address your concern and answering your questions. Also to examine you. Is it okay with you?
Okay, doctor, sure.
Firstly, can you tell me what your complaint or what you know about your health condition?
Yes, doctor, I have been complaining from a headache since 1 week. Started gradual, and now I have severe headache. It is not responded to any painkiller.
So I'm sorry for that, Mr. Sami. We are here to help you.
Thank you, doctor.
Can you tell me where's the exact site of this headache?
It is all over my headache, doctor. All over my head, doctor.
Can you describe the character of this headache?
Yes, doctor. It is dull aching headache.
Is this headache has any diurnal variation, increase in morning or in evening or
No,
after?
doctor. No, doctor. It is all over the time.
All over the time?
Yes, all over the day.
Increased by any position?
No, doctor. No, I didn't notice that. No.
You notice anything increase it or decrease it?
No, doctor. No.
Okay. You said it starts from 1 week?
Yes, doctor. It started 1 week. It is started gradual, and the progressive worsening now. Not responded to any painkiller. Not respond to anything. I feel tired, doctor. Really.
I'm sorry for that, Mr. Sami.
Thank you, doctor.
For this week, do you suffer from any headache before or
No,
any
never, doctor.
similar headache? First
No,
time?
doctor. It is first time, doctor.
During this headache, do you suffer from any another complaint like feeling sick or vomiting?
No, doctor. No.
Do you notice any change in your vision?
No, doctor. Didn't notice that. Anything?
Any change in your hearing or your smell?
No, doctor. No.
Do you notice any change in sensation in any part in your body?
No, doctor. Sensation? No, doctor. No.
Do you feel any numbness or weakness?
But to be honest, doctor, I feel my body weaker than before. I am not myself before. I am weaker than.
What mean by weaker? You can't do your daily activity or what?
Yes, doctor. Sometimes I feel myself weaker than before, but for sometimes only, not all the time.
You mean that headache struggling you for your daily activity and your daily
No,
life?
doctor. No, doctor. No, not exactly. But the weakness is interfere with my daily activity. Yes.
Okay. Do you have any difficulty in going upstairs or?
No, doctor. No.
Do you have any fever?
No, never, doctor.
Any lumps or bumps in any?
No, doctor. No.
Do you have any joint pain?
No.
Any weather preference?
No, doctor. No.
Do you have any heart racing or chest pain?
No, doctor. No, but I sometimes also I feel my heart racing. I don't notice, but for sometimes only, not all the time.
When you feel heart racing, during activity or during rest or any time?
I think during rest, during exercise, sometimes I think once a daily or like that, I feel, yes, you're right. I feel my heart racing, but for short time, not all the
In,
time.
bo in both rest and activity? In
Yes,
both?
doctor. Yes, yes.
Can you describe this heart racing? It is regular, like the sound of
Yes, doctor.
uh, the clock?
I think it is like clock pattern,
Mm,
but for short time, not all the time.
okay. You feel your heart beats rapid, more than regular at that time?
Yes, doctor. Yes.
Do you feel any chest pain?
No, no, never, doctor.
Any shortness of breath?
No, doctor. No.
What do you do to stop this heart racing?
It's still by, it is ended by herself.
Uh, do you have any swelling in your feet?
No, doctor. No.
Do you have any cough?
No, never, doctor.
Any bleeding from nose or sneezing or
No,
nasal
never, doctor.
obstruction?
No, no, doctor.
Do you have any tummy pain or tummy
No,
swelling?
no, doctor. No.
Any change in your bowel motion?
Bowel, no, doctor. No.
Uh, any change in the color of your eyes or your skin?
No, no, doctor.
Do you have any problem in water work in change in frequency or color or any
Yes,
change in water work?
yes, doctor. I go to bathroom. My water work increased. So I think since 2 weeks.
Increased frequency or amount or both?
Both, doctor. Frequency and the amount.
But any change in color?
No, doctor. No.
Do you have, you tell me that no change in weight?
No change in weight, doctor. Yes, yes.
Yeah. Do you have any burning micturition?
No, doctor. No.
So, sorry. Do you take any drugs,
Yes, doctor. I take.
any medications?
Yes, doctor. I take amlodipine 10 milligram,
Mm.
and I take um, captopril 50 milligram
Uh,
twice a
you,
day.
you diagnosed by hypertension?
Yes, doctor. I visit my GP since 1 month, and he tell me that your blood pressure increased. Give me one medication, not respond, and then two medication, and still my blood pressure increased.
Do you take, I'm sorry for that, Mr. Sami, do you take any other medications?
No, doctor. No, doctor. No,
Sorry for asking, but you take any recreational drugs?
never, doctor. Never.
Do you take do you have any allergy for any drugs or any substance?
No, doctor. No.
Okay. Do you change any increase in your shoe size or in hand size?
No, doctor. No.
Do you notice any shaking in your hands or any part?
No, doctor. No, never. No.
What do you know what reading of your blood pressure measuring?
Yes, doctor. Yes, doctor. I measure my blood pressure at my home and at the clinic. It always increased, doctor.
Mm.
Last reading today morning was 160 over 110, 110.
Uh, is this uncontrolled since discovered? Yeah, since 5 months not controlled?
Yes, doctor. No, since 2 months.
2 months.
Yes.
Discovered. Okay, but not controlled.
Until now, I don't. Yes.
Okay. Do you have any health problem you want to tell me about it?
No, doctor. I am football player.
Hmm. Do you have any history of syncope or loss of consciousness?
Never, doctor. Never.
Do you have any family history of similar condition or
I am adopted, doctor.
sorry for
Adopted.
that?
Never mind, doctor. Never mind.
Can I ask you about some social questions?
Sure,
You
doctor.
said your job is football.
Yes.
How this headache affect your job or your daily life?
Yes, doctor. I can't play since 1 month. I feel myself weaker than before. I don't have any energy to play. So it doesn't interfere a lot with my job. Yes.
Sorry for that, Mr. Sami.
Thank you, doctor.
We will do our best to help you.
Thanks.
Do you drink alcohol?
Never, doctor.
Okay, good. Do you smoke?
Never, doctor.
Okay, good. Can I examine you?
Sure, doctor. Sure.
General look for hands, general features.
Normal.
Hand check hands for any tremors,
No, normal.
any abnormalities in hands.
Normal, doctor.
Check pulse on both sides.
Pulse normal. Blood
Auscultate
pressure. Yes,
blood
blood
pressure.
pressure. Yes, 160/110.
Change in position. Standing.
No change, doctor.
Auscultation of chest.
Normal.
Auscultation of heart.
Normal, doctor.
Examination of muscle for lower limb for weakness or
Normal.
sensation.
Yes. Again, doctor, please. Check.
Weakness.
Weakness. No, normal.
Tone power. Tone
Tone power normal.
sensation.
Is normal.
Coordination.
Normal.
Upper limb also.
Normal.
Abdomen.
Normal.
Organs. Tenderness.
Normal.
Eye.
Eye normal, doctor.
Yes, okay, Mr. Sami, can I ask you another questions?
Sure,
Do you
doctor.
have
Sure.
any sweating or increase in sweating?
No, doctor. Never. No.
You notice any frothy urine?
No, doctor.
2 minutes.
No.
What's your concern, Mr. Sami?
Yes, doctor. What I have, and why my blood pressure not controlled till now.
There's many causes for your headache and your blood pressure. Your headache may be related to your high blood pressure. That may be the cause from kidneys, blood vessels, blood channels of the kidney may be affected. Also, we should check your hormones level. That may be the cause of blood pressure and the headache. Also, we will should involve the nerve doctors and the brain doctors to examine you and do some imaging study on your head and your brain. to search for the cause of headache.
Okay, thank you, doctor. But I have to be admitted or
Yes, you
as
will be admitted.
oh, okay, doctor. Okay, and it is treatable condition, doctor?
Mostly, according to the cause, we detect.
Okay, doctor. Thank you very much. Thank you. Do you need to eat anything, doctor?
No.
Okay.
Okay, Dr. Marwa, are you satisfied? Any more question, especially with ingestion?
I feel there is there is more questions.
No, doctor.
No, you cover
you
a lot of things.
yes.
You
Did
cover well.
yes, doctor. Yes, did it perfect.
There is missing some
Yes.
over-counter herbal like this, and it
Is
should be
normal?
perfect.
Normal? No.
No, let's go to the examiner question.
Okay, examiner
Just
question.
try to give her a clue. Okay, go ahead.
Yes, doctor. Okay, doctor. Please put your differential diagnosis.
Is this headache in young man complaining from hypertension?
Yes.
Maybe due to any cause from secondary hypertension, maybe renal artery stenosis, maybe Crohn's,
Good, doctor.
maybe Cushing.
Good.
Also, other causes may hyperthyroidism, but there is no symptom suggest hyperthyroidism.
Okay,
We
very
need to
good. Very good, doctor. Very good. Okay,
we need
go on.
to do also patient mentioned that he have palpitation and regular arrhythmia. We should searching by ECG, echocardiography, doing chest X-ray. Also essential workup for CBC or urea electrolytes. Electrolytes here, I think it's important to detect any
Can I know?
cause.
Yes, can I know which electrolyte?
Sodium, potassium, sodium, potassium mainly.
Yes, very good. Inshallah. Okay, if you now if you have a choice to ask the patient one question, another one question, what you will ask him? Only one question. Yes. Okay, doctor, you did it well. Okay, what is the most appropriate diagnosis from you will
for me, secondary hypertension for investigations.
Yes. What is the most appropriate diagnosis according to the symptoms of the patient?
Maybe
Patient have polyuria. He also have polydipsia and weakness.
yes.
Yes. Still another question. Oh.
You give me 1 minute, Kurt.
Hey, did it well, doctor. Really. Okay. If the patient had leg cramp. Patient also has leg cramp. Okay. What's your appropriate diagnosis?
Pushing.
No, doctor.
Pushing.
No increase in weight. Okay, it will be Coons. Yes, Coons, Dr. Bess. Coons. Okay, what's your investigation?
I said essential lab investigations, so electrolytes, more important, also abdominal CT and
Yes, doctor.
measurement of aldosterone level from the I forget the
Yeah.
name of the test.
Adrenal vein sampling.
Uh,
Oh,
ad- what's the name?
adrenal vein sampling.
Oh
Adrenal vein
yes,
sampling.
yes, from the adrenal vein.
And yeah. Okay, doctor. Okay, what else? And aldosterone issues. And what else other than cones? Patient adopted. What will be familial in hypertension with hypokalemic?
Hypertension, hypokalemia, I said Cushing, but no suggestive symptoms.
Yes, doctor.
Cones, little but
Yes, doctor. Very good. Liddle syndrome. What is the difference between Liddle and Coons?
Liddle, I think is normal blood pressure or hypertension.
No, high blood pressure with hypokalemia. But the difference is yes, decrease aldosterone and renal ratio. Okay, doctor, you did it well. Very good. But the most missing thing is he has weakness and polyuria and headache. So he will have this hypertension with hypokalemia. So we have to ask about leg cramp. The same case in last diet in Ajman Emirat. But the question is يعني before beside headache, patient was headache and hypertensive with hypokalemia. So it will be easy, more easy, yes. So the patient will be Coons, maybe Coons is primary hyperaldosteronism and also bilateral idiopathic hyperaldosteronism and Riddle syndrome and renal artery stenosis and Cushing. There is hyperkalemia with hypokalemia with hypertension. Investigation will be sodium and potassium, will be potassium low and sodium will be high, and also serum aldosterone and serum renin. It will be increase the ratio between aldosterone and renin, and also the last test, but last test to differentiate between primary hyperaldosteronism and bilateral idiopathic hyperaldosteronism, it will be adrenal vein sampling. And also Liddle syndrome, it is autosomal recessive disease, the same as Coons, but only the difference, it will be decreased aldosterone and decreased renin. Also, it is renal artery stenosis, but it will be pulmonary edema or fine basal crepitation at the lung. Patient will have abdominal pain, and the investigation will be different. We'll do Doppler on renal, and also we'll do CT or MRI angiography. Thank you, Dr. Marwa. You did it well, really. Thank you.
Okay, thank you, Dr. Mahmoud. And
thank you, Dr.
Well done. Yeah, well done, Dr. Marwa. Please write the case scenario for him, Dr. Marwa.
I sent it.
Okay, good. As a first case in the long practice, clinical hygiene with this meeting, you did great. Really, it's a difficult scenario, but your approach was well. Almost you approach the case, and almost you reach to diagnose. Apart from, yes, the hypokalemia you didn't ask about, but I guess you were about to reach it. The hypokalemia and the weakness, and also the cramps, as Dr. Mahmoud said. Apart from this, the herbal oil also very important. You might find like licorice or some herbal induced hypertension. But at the end, it's clear hypertension related to, sorry, headache related to the hypertension. I think you catch this, but it was how to access the hypertension cause. This is the only thing missing in your approach. So what do you think about adopted in bases? Whenever you hear adopted, first
Adopted
thing,
child, that
don't,
means not known family, is it mean?
yeah, he
Oh.
doesn't have father or mother or biological
Mm,
parents. But don't
mm,
say I'm sorry for that because a lot of them
mm,
there.
mm.
This is the first thing. The second thing, in bases, whenever you have adopted, it's a clue for some inherited
Mm,
condition.
mm, mm.
Yeah, so you have to put it in your mind. What are the possible causes of inherited condition in hypertension? You said it, Liddle and the
Well,
cones.
and the polycystic kidney, Dr. Basim, yes.
Polycystic kidney, but there will be another finding like blood in urine, stones, renal colic,
Yes.
I think
renal
in
pain.
polycystic kidney also because of headache and brain aneurysm.
Yes,
Some,
I'm
mm,
sorry. So let's go back to the other cause of hypertension, renal artery stenosis in male. If you don't find the reason, you might think about renal artery stenosis, but it's not the common cause. Dr. Marwa,
yes,
the most common cause, if you don't have clear cause of hypertension in female,
in female,
yeah, with pulmonary edema.
hypertension and pulmonary edema.
Yes, I said in male it's renal artery stenosis.
Mm,
In females, what the possible cause?
Fibrodysplasia.
Yes, fibroid
Yeah.
dysplasia.
mm.
It's the same mechanism, but in this both condition, what you will have in renal angiotensin system, or sorry, aldosterone, renal aldosterone system, the ratio, I mean. What do you think? The ratio here will be high or low?
Um,
Renal aldosterone.
Yes, you have renal artery stenosis. What do you think the renal aldosterone
Renal
ratio?
will be increased.
And the aldosterone low.
Oh,
So the
the
ratio will
risk
be high.
increased. Oh.
Yes. But in this condition, cones, what do you think?
Cons no renal. Uh,
The aldosterone high.
renal also high. Both are high with
Yes.
ratio is decreased.
Yes, exactly. Why? Because the aldosterone itself is high in cones as hyperaldosteronism. Okay,
Mm,
this is another difference. The same as for Lidl,
mm,
but both will have hypokalemia, right?
mm.
So this is the difference between all conditions.
But in
You have
fibrodysplasia also hypokalemia present?
no
Mm.
the same features of renal artery stenosis. The patient might
Oh,
present with pulmonary edema, sudden
mm.
increase of blood pressure up to pulmonary edema. Patient might present with flash pulmonary edema. Okay,
Especially after ACE inhibitors. If they
exactly.
take
Yes.
ACE inhibitors, they will make flash
Yeah,
pulmonary.
that's why it's contraindicated.
Mm.
Okay, pheochromocytoma also one of the causes, and you screen for it. You ask about shakiness, which is very good question, and the headaches as well. It might be there. What do you think other causes if you have endocrine issue? You said for the patient hyperthyroidism, or sorry, you said it might be hyperthyroidism related to the tachycardia. What
Mm.
other causes related to the hypothyroidism might cause hypertension? For Cushing as well, by indirect way. It's common scenario also in exam.
And
So the patient will gain weight and he will have
water retention?
no, he will have obstructive sleep apnea. Indirect way, I
Mm,
told
mm,
you. Cushing and
mm,
hypothyroidism, patient might have obstructive sleep apnea due to gain of weight or weight gain.
mm.
Okay, and also obstructive sleep apnea can cause hypertension. So you have to screen all these. Going to the heart,
Yes.
you screen the heart by asking palpitation and chest pain. What do you think in heart can cause hypertension? We are trying now to do it system by system because you
Mm.
might have one condition in not two, one condition, two condition in the heart can cause hypertension or can lead to hypertension.
Coarctation of the
Chest,
heart.
perfect, yes, coarctation. Okay, so what you have to do in the examination, if you suspect
measure اللي هي blood pressure in both arms
Yes,
or upper and lower.
excellent, and radial delay or radiofemoral delay. What else in the aortic? Sorry, I said it already.
Aortic stenosis.
Yes. Yeah. So these are
Aortic
the
articulation.
coarctation and aortic
Oh,
stenosis. These are
stenosis.
the possible causes of hypertension in the cardiovascular.
Hmm.
Okay. And in the chest, I think in the chest it will be like indirect, but it's not common. I mean, if you have hypoxia long time, what you expect the cause of hypertension if the patient is chronic hypoxic patient?
Polycythemia.
Exactly, polycythemia, and polycythemia itself can cause hypertension.
Hmm.
Plus, if the patient is having, for example, hypoxia, like obstruct sleep apnea, it might be also the reason of hypertension. So either by obstruct sleep apnea or by, as you said, polycythemia as reactional or reflex. Okay. So we finish the causes of renal and suprarenal. We said the cause of heart. We said the cause of chest. Yeah, other. What do you think about others? If you said affectitious or iatrogenic, what do you think
For
can cause?
hypertension or for
Yes,
headache?
hypertension and headache, because the hypertension itself will cause headache, right? So what can lead to hypertension and headache from outside the body?
yes,
What do you think?
licorice.
Licorice, yes. This
Licorice.
is as a herbal, yes, as a herbal.
Yes, as a
Okay.
herbal. Mhm.
What else apart from herbal?
Caffeine.
Hmm?
Caffeine, maybe.
Excellent. Yes, caffeine. What else? This is natural. What about the chemicals? What do you think some of chemicals
Cocaine,
can?
yes.
Yeah, cocaine. So drug induced or yes, drug induced cocaine, amphetamine, and so on. So this is from outside the body. Yeah, one more. Endocrine. You ask about it, and it can be the reason of hypertension. Hypertension, yes.
Yes, pheochromocytoma.
Yeah, we said it in the endocrine. No, I will say this one from the brain, pituitary.
Acromegaly.
Acromegaly, yes.
Excellent. Yes,
Acromegaly.
acromegaly. And it will be also unexplained hypertension along with the manifestation of acromegaly. Large hand, large feet, as you said, and you screen for it, Dr. Marwa. And you will have also high blood sugar or hyperglycemia. Okay. I guess we cover the most of the causes from the brain, pituitary, endocrine, thyroid, Cushing, hypothyroid, obstructive sleep apnea, the heart, coarctation of the causes I'm mentioning, you have to screen for, and they are sometimes coming in cases as a case. Okay, so the diagnosis either be like this or as differential. Okay, aortic stenosis, coarctation, and the medication we said, and the renal or suprarenal, the causes of suprarenal like primary hyperaldosteronism, cons, Liddles, as also congenital with hypokalemia. But particularly in this patient, you have to think about hypokalemia with hypertension.
Mm.
Okay, what are the differential and the proper differential in this patient? I give you two clues or two manifestation. You have to give me three causes or differential related to hypertension with hypokalemia. What you can give me? Hypertension with hypokalemia.
We said cones or Cushing.
Okay, cons. Cushing.
Cushing. Liddles.
One Liddles. The last
Renal artery
one more.
stenosis.
Renal
Primary.
artery will be with hypo. No, I don't think will be with hypo.
Hypokalemia, Dr. Bassam?
Yeah. Yes.
Yes, renal
Hypertension.
soon.
Hypertension with diuresis. Patient
Yes, yes.
hypertensive and taking diuresis, he will have also hypertension uncontrolled, especially if untreated or untreated the cause. Plus the diuresis effect on hypokalemia or the electrolytes, so you will have hypokalemia. Okay, so these are the four differential in this scenario: Cones, Cushing, Liddle, and last is medication, diuretics particularly. Okay. If you suspect Cushing, what you have to do, Dr. Marwa? Cushing, something will help you in the diagnosis. Bedside test. Bedside test. Dr. Mahmoud.
urinary
Urine dipstick for glucose.
urinary
Okay.
cortisol for diagnosis of Cushing itself.
Okay, Cushing can be okay with hyperglycemia,
Hyperglycemia,
glucosuria,
hypokalemia,
glucosuria. Yes,
metabolic
yes. Okay.
alkalosis also.
Excellent. This is the one. Metabolic alkalosis. So
VPG.
blood gas. Yes, blood gas. It will show you metabolic alkalosis. And also metabolic alkalosis you can find in the diuresis, because most of the diuretics can lead to metabolic alkalosis. Okay. So you have to mention this test as well as the urine or the urinary dipstick or the urine analysis. You have to mention also urine potassium, okay, to rule out any renal cause of hypokalemia. In this condition, it will be high because the patient is losing potassium. Okay. I guess we cover most of the scenario of the causes and how to investigate, as you mentioned. Start to do it blood test, image, and advanced image, like as Dr. Mahmoud said, ultrasound Doppler for the renal arteries, and you can even do CT angio of the renal vessels, okay, and renal vein sampling. Sometimes it could help. The management, how you think the diagnosis or the management should be?
Yes, spironolactone, yes.
Yeah, as control of hypertension along with
aldosterone, yes, hyperaldosteronism, spironolactone.
antagonist, aldosterone antagonist. Okay, but this is pharmacological. Again, Dr. Mahmoud, don't
Yes.
start with the pharmacological. You always thinking about the pharmacological, but no think about the
Yes,
initial management. So
patient
what you think here is very important in non-pharmacological management, Dr. Marwa? I will ask Dr. Marwa this question.
Non-pharmacological decrease salt
Excellent.
and
Yeah.
diet for
From the
increase.
first word, yes, I know what you want to say. Yes. So salt, reduce salt intake or salt restriction, plus education counseling about the,
Changing
yeah,
lifestyle,
exactly. And
exercise.
dietitian multidisciplinary team approach. Don't forget the hypokalemia here is very important to treat because this patient is symptomatic hypokalemic, periodic hypokalemic paralysis. He has a lot of cramps and weakness due to the severe hypokalemia, and you have to treat it. Okay.
Yes.
This is for hypokalemia and the non-pharmacological as well as for the multidisciplinary team approach. Then pharmacological, as Dr. Mahmoud said, it's drug of choice, spironolactone antagonist or aldactone antagonist, spironolactone. You can also refer the patient, of course, to the cardiology. Some of these patients will have left ventricular hypertrophy, and you have to mention the ECG for two reasons here. Why you want to do ECG in this patient? Two reasons. Give me the two reasons. What you suspect in the ECG? And you have to mention it in the exam.
Hypokalemia is the first.
So what you will find?
Long QT.
Excellent. And along with what else?
Short B wave. Short B.
PR.
I don't remember. But
What's characteristic for hypokalemia? Characteristic finding in ECG.
Yes, big B wave, Dr. Bas.
No,
No, pick
no,
tweave with
hyper.
hyperkalemia. Yeah.
Mm.
What's extra
I
wave?
think
There is
flat
extra wave.
U
What's
U
called
wave. U
U
wave.
wave. Yeah. So you have to mention the ECG finding as well as
In hypo, I think flat T wave or
flat
low.
and yes, flat wave with U wave.
Mm.
Is pathological or pathognomonic wave for the hypokalemia. Okay, the other finding you might have what in the ECG due to hypertension? What you will think?
Is
I
it
mentioned it already.
left
Let's
Yeah.
ventricular hypertrophy?
Yes,
ventricular
left ventricular
strain.
hypertrophy, strain or hypertrophy. Yes. Okay, I think this is enough for this question for this case. Any question for this scenario or but really nice case with nice history, Dr. Marwa as first time. Keep like this your approach, but don't or never give up whenever you are reaching to the concern. Don't be panicked. You didn't reach the diagnosis. Sometimes the
I reach
examiner,
in this case I reach to the concern without the diagnosis.
okay, you can tell him, I have some possibility. I have to
Mm.
roll some of them out and I have to do blood test to confirm what the possible cause. If he insists to know what the possible cause, yes, you'll be in trouble, but okay, mention some of at least you put in your differential one,
Mm.
right? So in this scenario, you can't say any of the possibility. You mention, for example,
Mm.
pheochromocytoma, one of the
Mm.
possibility. If you don't know at all, it might be correct. If especially if he asks you what the condition, doctor. But if you said
I said mm.
yes,
I
go
said
ahead, go on.
hormonal causes.
Okay, good. Some hormones, some proteins
Mm.
increase in your blood causing this. We have to do some blood tests, to do some scans to confirm the diagnosis and to rule out other possibilities. That's it. If he insists, no, tell him any condition, whatever. Then with the examiner, he might give you some clues while you are saying the differential. He will try to help you, especially in these difficult conditions. And again, if you mention it in the second, at least the third, better than not to mention it at all. Okay. Of course, it will be good to mention it at the first, if not at the second, if not at the third, if not, good luck. He will minus you in the differential and the clinical judgment as well. Okay. But try to put it in the three differential. Any other question, Dr. Marwa? Dr. Mahmoud?
No, Dr. Bassem, thank you very much.
Okay, so let's
The
read the
voice is
scenario.
very low for me.
Sorry?
Your voice very low at
Me?
me.
No, me or Dr.
Me
Bassem?
or
My voice good.
or both?
I listen Dr. Bassem clearly. Even he will talk. I will listen to him.
Thank you, Dr. Mahmoud. Always
Welcome.
appreciated. Dr. Marwa, you can hear us or maybe your mic. Okay, I will read the scenario until Dr. Marwa, I think she disconnected and will join back.
I can
Mrs.
back.
Okay, so the sound is clear now, right?
Yes.
Mrs. Sheila or Sehila Harrison, 63. Thank you for seeing Mrs. Harrison so quickly. She has been complaining of gradual progression of difficulty in walking for 5 months with some numbness in her feet. She has chest pain and a long-standing cough from her chronic bronchitis. She smokes 40 cigarettes a day. She uses a salbutamol inhaler and needs paracetamol for the pains. Please see and advise your sensory GP.
What
So
is
you
that
have,
book? What is that book, Dr. Bassem? You
it's
put
okay. At least, at least you have the history, medical history, you have medication
yes,
history, you have the complaint. So focus on this point.
yes,
It's
Dr.
good to
Bassem.
have like this.
You put me in the corner with old age, old age,
No. You
patient
can
old
reach
age.
it.
Okay, Dr.
And
Marwa, let's start. I give
there
you
is
Dr.
also
Marwa patient.
no, I will not start. I will give you 1 minute. I will read the comment and prepare the patient well, the
Okay.
approach and the patient name. If you mention
Yes.
any name wrong, I will
Yes.
give you
Okay.
zero.
Okay,
Okay.
Dr. Bassem. Okay.
Okay. Let's read the
Okay.
comment now
Thank you.
until uh, Angiotensin-renin ratio, yes, little renin and aldosterone. Yeah, aldosterone, not angiotensin. Renin aldosterone ratio, okay. Hyperglycemia, yes. Hypercalcemia, yes. If you have some symptoms of hypercalcemia, you have to think about men. If you have acromegaly, for example, with hypercalcemia, think about men. Men one. Cohen's very interesting case. I really appreciate that. Thank you. Can you please, Dr. Rawan, can you please summarize the case? I missed it. So, in summary, patient, young football player, patient, or yeah, professional football player, he has headache recently and newly diagnosed hypertension. The headache is dull aching. He is always hypertensive in his reading. Started on some medication. Apart from this, he has some weakness. You can add also to this weakness cramps, muscle cramps. So it's pointed to hypokalemia or periodic hypokalemic paralysis. And the examination, nothing important apart from hypertension. You can add urine dipstick. You can do examination of the heart, find basal crackles if you suspect pulmonary edema, and that's it. You can also auscultate. Don't miss auscultation of the renal artery area for renal buoy. Okay? It's important just to act about doing that. You might hear, but I think it's difficult to hear. But anyway, just put the stethoscope there in the flanks. This is one of the important steps you have to do in any hypertensive patient, plus the radio-radial delay and radio-femoral delay, along with aortic stenosis or aortic area auscultation for aortic murmur stenosis or aortic stenosis murmur, ejection systolic murmur. Hypertensive heart, you might have displace of the apex, so you can also say that you can comment on the apex beat. Sometimes you will have heaviness in the apex of the apex beat due to aortic stenosis. Or if there is some other valvular disease, you might have displaced apex. If the patient, for example, having a hypertrophic change in the left ventricle. Okay, Dr. Amal added carboxynolone. I think this is also CNS stimulant. I'm not sure. So if you can write what the mechanism of action of this medication. And Dr. Rabia said vasculitis. Of course, vasculitis one of the possible and hidden cause of hypertension. But again, you will find a lot of symptoms related to the rheumatology, joint pain, skin tightness, stiffness. So it will not be only hypertension. You will have other finding of vasculitis. Isn't Dr. Rabia? You want to add anything else plus what I said?
No, Dr. Basim, you are right.
So skin rash. Sometimes you will have this difficult swallowing, dryness of the eye. So I mean the autoimmune complex finding. After that, you can find also the hypertension due to the vasculitis. And don't miss the cause of what's called Takayasu arthritis. It's also one possible of hypertension cause. But you will have also the other manifestation of Takayasu arthritis, middle-aged female, Asian, and some skin rash, unequal pulses in both sides. But it will be diagnostic from the start. You might see the patient as Asian patient and middle-aged female with skin rash, with the headache, and the pulse will be unequal or sometimes absent pulse. I mean the radial one. You have also to ask about the fever, history of fever. Patient might have fever, chronic fever, and that's it. Any comment from others, please, before moving to next scenario? Dr. Mahmoud,
Yes, Dr. Basim, ready?
ready? Okay, let's start. Here you go.
Good morning. I am Dr. Musa, doctor in the medical ward today. Can I confirm your age, your name and age, please?
My name is Sheila Harrison. I'm 63 years old.
Nice to meet you, Miss Sheila. How would you like to call you?
You can call me Mary.
Mary?
Okay, yes.
Okay. Nice to meet Miss Mary. Miss Mary, I am here to discuss about your medical condition. Is it okay with you?
Yes, it's okay.
Okay, Miss Mary, can I know how much you know about your condition? Could you tell me
Yes,
more
doctor.
about your condition, please? Yes.
I have weakness in my legs. I can't walk. I walk by difficult in walking for over the last 5 months. Last month it has become more severe.
Okay. Okay, I'm sorry to hear that, Mrs. Mary. But can I know what do you mean about weakness? Do you can't walk or there is pain during walking?
I feel weak while I'm walking. I can't. I fall twice. My get. I can't. Um,
Okay,
s-
I am so. Okay, I am sorry to hear that again, Mrs. Mary. But do you feel your leg is weakness?
yes,
Yes. Okay. What about your hands? Your arm?
my hands are okay.
Okay. Okay. Is there is weakness in one limb or the on both in one leg or the both leg?
Both legs.
Okay. So for that, Miss Mary, Miss Mary, do you feel that your leg is floppy or stiffy?
I feel it's stiffy.
Stiffy. Okay. Okay. Do you feel any numbness in your leg?
I don't feel. I think my sensation lost in my feet and my legs also.
Below your knee or all your limb or your leg?
No, about it started from my feet, then it is progressive up to the chest level.
To the chest.
I can't feel.
Okay, Miss Mary, I'm sorry to hear that again. Can I know if you have any history of unsteadiness or fall or shaking of the hand?
Yes, doctor, I fall twice because of this difficulty in walking.
Okay, so you are fall due to weakness of your leg, yes?
Yes.
Okay, you fall in your in front or the side?
What you mean?
In front? Okay, okay, no problem. Do you feel? Do you notice any shaking of the hand?
No shaking.
Okay. Any abnormal movement?
No movement. No abnormal movement.
Okay, are you have any problem in your smell,
No, doctor.
your vision,
No, doctor. It's okay.
hearing, or
No,
taste? Any numbness in your face?
no, doctor. It's okay.
Did you have any headache?
No headache, doctor.
Okay, any fits, sorry.
No also.
Okay, can I know what's your any problem in your memory?
No, I have no problems in my memory.
Okay, very good. Okay, are you having any history of trauma?
No, doctor.
Okay. Mrs. Mary brought in my notes, I see that also you have chest pain and the
Yes,
cough. Okay, could you tell me more about this? When
yes,
this
doctor.
is
I have constant dull chest pain in the central part.
central
It's
part? Okay.
my chest.
Okay, are you have any, is the chest pain increase with exertion or all
No,
the
doctor.
time?
It isn't all the time.
All the time. Okay. Okay, is this chest pain, did you notice that he's worsen with like breathing or coughing?
No, it's constant pain.
Constant pain. Okay, if you give you how much you grade your pain 1 is minimum and 10 is maximum. How much you give this pain?
Now there's pain at 8. Before it was a mild pain, but it is progressive. Now it's severe pain. I can't sleep from this pain.
8 over 10?
Yes.
Okay, do you need any painkiller? Do you have
No,
this pain?
doctor, I have taken already.
Okay,
Thank you.
okay. Welcome. Mrs. Mary, also you have a cough. Yes, do you have now a cough? Do you have now a cough?
Yes, I have cough from a long time.
Okay. Did you notice that their cough increase with rest or with exertion or with any pollens?
Not the cough is constant, and it's with me from long time. I am a smoker, doctor.
Okay, is this phlegm?
Yes,
What is the color of the phlegm? Can I know?
it's a white color.
White color, okay. Any odor to the phlegm?
No, no odor.
Okay, can I know what the amount of this phlegm? It is
It's a small to moderate amount.
any streaks with blood?
No, doctor.
Okay, very good. Mrs. Mary, are you have any fever?
No fever.
Any loss of weight?
No, doctor.
Any loss of appetite?
No loss of appetite.
Any lumps or bumps on your body?
No, doctor. I told you I lost my sensation.
Okay, okay. Okay, can I know please, are you have any racing heart?
No, doctor.
Okay, very good. Any leg swelling?
No, sorry.
Okay. Okay. Are you have any joint pain?
No joint pain.
Any back pain?
No, doctor.
Okay. Are
Only
you
my
have
chest pain. This is severe pain.
okay can I know the exact site? The exact site exactly?
This pain like a band-like pain. It's from bilateral pain, like a band in my chest.
Okay, the site.
The side
It is the center here, center or in the side?
central, but yeah, more in central, but it is like a band also.
Okay, can I know if this pain goes or travel to anywhere, like your shoulder or your back?
No, doctor. This constant pain in the same place and very severe.
Okay. Are you have any tummy pain?
No,
Do you have any heartburn or acid brush?
no, doctor.
Okay. Any throw up or throw up blood?
No, 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 doctor.
Okay, very good. What about please? What your water work? Any change in water work? Like increase?
Yes, doctor. I have some incontinence.
Some you can't control your water work.
Yes.
Okay. Okay. And also any change in your bowel?
No change in bowel.
Any loose motion or constipation?
No, it's normal bowel motion.
Okay. Sorry, just to confirm, did you have any history of trauma?
No, doctor, no trauma at all.
Okay.
I can't
Okay.
get outside my house because of this abnormal walking. I usually fall.
Okay. I'm sorry for that, Mrs.
Mary,
Mary. Okay, Mrs. Mary. Can I know are you have any long-standing disease?
no, doctor, just this cough from many years due to my because I am a
You
smoker.
are, okay, you are in salbutamol, yes?
Yes, I take
How
this
many
in Malaysia.
how many times did you take this?
Maybe once per day
Okay.
or
Um,
less.
okay, are you any over the counter? Any drugs over the counter?
Sometimes I take paracetamol for the chest pain, but it's not work.
Okay, can I know please how long you have this chest pain?
Okay.
Since 1 day or hours
Since
or
no, it's for 6 weeks,
for 6
but
weeks?
it is
Okay,
gradually increased.
gradually increased. Okay, Mrs. Mary, what do you do for a living?
I'm secretary.
Okay, still working, yes?
I am retired.
Okay, Miss Mary. Miss Mary, how much in my notes I see you are a smoker. You are still a smoker?
Yes,
How much? How many cigarettes per day? Or how many
about
packs?
40. About
40.
40 cigarettes.
For how long?
For about 40 years.
40 years. Okay. Miss Mary, I advise you to stop smoking. You put yourself at a risk because smoking has bad effect on your lung. So, if you would like, I can refer you to smoking cessation clinic. They can help you about this issue. Okay.
Okay, doctor.
Okay.
No
Do you
problem.
drink alcohol?
No, never, doctor.
Never. Okay. Very good. Ms. Mary, do you have any family history of cancer or stroke or early death?
No, I don't have.
No family history. Okay.
Mm.
Ms. Mary, did you have any history of travel recently?
No, I don't travel.
Okay. Are you have any history of surgery or hospital admission?
No, doctor.
Okay. Did you have any blood transfusion, sharing needle, tattoo?
No, doctor, I don't have.
Okay. With whom you are living?
I live alone.
Okay. You need any support at your home?
No support, doctor. I depend on my neighbors. I
Okay.
can't do my. I can't help myself.
Okay. Okay. Can I examine you, please?
Okay, doctor.
Okay. First, I will examine the hand for pulse and blood pressure and any nicotine staining at the fingers and any clubbing.
Only nicotine staining.
No clubbing.
No,
Okay. I will examine the pulse and the blood pressure.
normal.
Normal. Okay. Proximal myopathy.
Yes,
Yes, there is
present
proximal
proximal.
myopathy. Okay. Okay. Then I will examine maybe. تمام. Then I will examine the leg. No, I will examine eye for any pallor and or conjunctiva. Any pallor,
No,
any pallor, no. Any jaundice, no.
no,
Okay, the mouse for any mouse for any central cyanosis.
no
2 minutes
sinus.
left.
Okay, I will examine GVP for any GVP enlargement.
No, normal.
Okay, then I'll examine chest for chest expansion.
This is normal.
Normal, not decreased.
Mm.
Okay, then I will examine chest expansion. I will examine for bibasal crepitation or apical crepitation or bronchial breathing.
Normal.
No bronchial breathing. Okay, okay. Then I will examine the heart for B2 and pulmonary hypertension.
Normal.
Okay. Then I will examine the leg. Is there is weakness? There is weakness.
Yes, weakness.
Weakness, flexion or extension.
1 minute.
Okay.
Mm,
Power decreased, yes.
yes.
Power decreased and the tone
Increased.
increased.
Non stiff يعني.
التون increased
Mm.
والباور decreased. Okay.
Mm.
reflex
It's exaggerated.
exaggerated. ماشي. Okay. And also abduction and adduction.
Weak,
Weak. Both abduction and adduction? Yes.
yes, but one more, but I don't remember now.
Okay.
One more.
Okay. Coordination
Intact.
intact. Okay. Mrs. Sami, Mrs.
No
Mrs.
time
Mary.
left.
Okay. Better.
No time left.
Okay. Examiner. Lose the concern. Okay.
Okay, I will give you 1 minute for the concern. Please
No,
go
I
ahead.
didn't.
No, you have to address the concern and to learn how to address it. Give him
Okay.
concern, Dr. Marwan.
Okay. Mrs. Mary, do you have any concern?
Yes, doctor. What I have, is it cancer or not?
Mrs. Mary, I appreciate your concern, and your concern is valid. But according to your examination and you have a problem. Cancer is maybe is likely in your condition due to you are a smoker and your symptoms. So we will do some investigation and scans to exclude if there is any cancer. Also, I advise you to stop smoking. Okay. Do you have any other concern?
No, doctor. Thank you.
Okay. Thank you.
Okay, examiner.
Present your case.
Okay, today I examine Mrs. Sheila, sorry. Mrs. Sheila, he has progressive difficulty in walking, 5 months, and it is progressive worsening over the 5 months. And also he have numbness in the feet. Also he have chest pain and cough. Chest pain, it is central chest pain and grades 8/10. And also she has cough and has a history of chronic bronchitis, which she take bronchodilator. She has a past history of smoking 40 cigarettes per day. On examination, the lower limb there is on examination there is the nicotine staining, and also there is proximal myopathy. And on examination, the lower limb there is decrease power and increase tone, and reflex is exaggerated. Meniscal signs upgoing. So it has a features of upper motor neuron lesion. My first, I have a list of differential diagnosis. On the top of my diagnosis on the top of my list, it will be a cancer, maybe cancer lung, and maybe also cancer tumor in the spinal cord or tumor in the brain. Also, it may be a part of paraneoplastic syndrome, and the major the cancer in the lung and has paraneoplastic syndrome. So what we are going, okay.
What will you do for this patient?
Okay, first I will admit this patient. I will do CT brain to exclude any signs of hemorrhage. And also I will do PEN CT to the lung X-ray, and also I will do MRI on the spinal cord, maybe the source of the cancer in the spinal cord. Also I will do basic investigation, CBC and liver function test and kidney function test to see if she has any anemia. Also so
What is the most important and urgent investigation for this patient?
it will be CT. No, MRI. No. I will do CT brain. This is the most urgent, and I will do MRI spine.
Yes. Okay. How you will treat this patient?
First, I will do here MRI to exclude any compressing in the spinal cord. I will give here steroid. Then I will do multidisciplinary team from neurologist or neurosurgery. I will give here painkiller.
Okay.
Okay. Very good.
Thank you.
Thank you. Okay. So I think in this case is compressor spinal
Okay,
cord.
wait.
Yes, spinal cord compression with
Okay.
Yes.
with sensory level. Yes,
Perfect.
Yes.
I still
I get
2 minutes.
I get it at last.
Okay, but 2 minutes left for the examiner, so I will continue asking you. Okay,
Okay, doctor.
tell me. You said I will do only MRI. What about blood test? Any blood test you want to do?
Yes, I will do blood test with CBC for looking for neutrophil and anemia, hemoglobin and white blood cells. And also I will do INR and the bleeding profile.
Why? What type of anemia you suspect?
I suspect macrocytic macrochromic anemia, hypochromic anemia.
Based on what?
Chronic illness.
So the chronic disease, anemia of chronic disease, will
Chron-
be microcytic or normocytic?
It will be normocytic. Yes.
Yes, exactly.
Yes.
Okay. What other investigation you want to do?
I will do MRI to spinal
No,
cord.
no. Again, I'm saying blood tests.
Blood test. Smoking. Yes, I will do vitamin B12 and folic acid. No.
Okay. Yes,
Okay.
right.
Yes.
So you will
Okay.
do vitamin for also nerve affection. You suspect also
Yes.
like subacute combined degeneration, one of the differential, because patient
Yes.
having cerebellar syndrome. Okay. Let's do other specific tests for this diagnosis. What you do? And you mention it in the differential.
It is paraneoplastic syndrome. Yes, I know.
Yes. So yes, what the screening?
But the screening, I didn't remember really. I don't remember.
Yeah, I'm not expecting to say anti-U, anti-Ho,
Yes.
this antibodies, but at
Yes.
least do say I will do screening for paraneoplastic syndrome antibodies. Okay.
Yes,
But
doctor. Yes.
for example, anti-U, anti-Ho, this what I remember also. I'm not remembering all of them, but these are two of them. But you have to say screening for paraneoplastic syndrome. Don't miss screening for CO2 or CO poisoning because this patient is heavy smoker, right?
Yes, doctor. Yes,
So
doctor.
you can do blood gas for this.
Blood gas or
Okay.
what, Dr. Basim?
For CO poisoning.
CO poisoning.
CO
Yes, yes.
hemoglobin. Yeah, CO hemoglobin.
Okay.
Okay. Yes, it's right to start, and it's well fair to start doing MRI spinal cord.
Because yes,
Why?
there
There
are
is
uncontrolled water
compression
work.
signs and symptoms. Yes. But you have to say also the blood test. You should do blood test for any patient admitted. You will not start by MRI, right? You will say I will do MRI urgent, but I should do some blood tests, basic workup.
Yes.
Even for if you suspect intervention, you have to do what's called. You want to interfere. You want to do surgery. What you have to do? It's basic question. Suspected surgery for this patient, right? You want to do surgery.
Yes, I will do surgery.
Okay, what blood test you should do before any surgery?
INR.
Exactly. So coagulation profile, simply.
Yes, coagulation
It's one
profile.
of the basic workup, but it's very
Yes.
important. If the examiner asks you and you said INR and he said to you why, what the benefit of INR, you can tell him for the sake of surgery, patient will have surgery soon, so I have to do this test. Okay, don't
Yep.
miss the basic and don't also miss the specific blood workup. In this condition, paraneoplastic screening And you can say also vitamin screening if you suspect vitamin. Okay, let's hear Dr. Marwa comment. I just want to ask you for the 2 minutes, then I will comment on
Only
you.
one comment. He didn't offer any support. She is live alone. No one help her.
Okay,
Bس,
this is the only support. This is the only comment.
Also, the character of pain, of chest pain, and not ask about what
Stitching.
increase, what decrease. In this scenario, this chest pain increase by coughing or straining, breathing. Also, not ask about other causes of myopathy or weak muscles, history of steroid taking. She is chronic
Yes,
smoker,
inhaler.
maybe
Yes,
take steroids for long time.
steroid. Mm.
Perfect.
Also
Yes,
about the nutritional status, if she take
yes,
enough
diet.
vitamin B12 or not.
Perfect. Yes, this one also. B symptoms. He didn't ask B symptoms at all, right?
What B
Weight
symptoms?
loss, the weight and the appetite.
No, I ask
Is there,
Dr. Basim. I ask
you
about
asked?
the weight, yes. Ask weight
Ask
وفيفر
about the weight or appetite.
appetite وفever. And I ask also
Okay.
Dr. Maro, I asked about chest pain, increase with cough or exertion.
I
I
think he
remember.
asked also.
Yes,
Yes, yes, he
you
asked
you
that.
said ask about cough and excision, not ask in general question what increase. You said cough excision. I said no, but what
Yes.
in general? If there is
But why chest pain 8? Why chest pain? I don't know.
Herbert.
radicular pain.
Yeah.
Radicular pain.
Okay, from the the mass
Palpation.
itself. Okay, so it's Smith's, right? Or spinal lesion with
Dr. Basim,
cerebellar. Yes, Dr. Ravi.
before we proceed forward, Dr. Marwa, what is the case?
Yes, this is what I should ask also. So
Spinal
paraneoplastic
cord
syndrome.
compression.
Spinal cord
I will read.
compression from what?
I will read from the case
Okay,
explanation.
a spinal
The
cord
case.
compression due to myths or original.
In this case, illustrate how spinal cord compression in the thoracic region may present. Causes of neoplastic spinal cord compression include extradural, metastatic spread, particularly
Yes.
from lung and the breast. Also,
Okay.
onset is usually more acute، يعني more acute than this case في الحالة دي. أو extramedullary زي المننجيوما والنيوروفايبروما، أو intramedullary زي الجلايوما، بس في الجلايوما هيكون يعني يعني over many years الكورس بتاع البروجريشن. This case illustrates that radicular pain at the site of the compression اللي هو thoracic band-like pain worse on straining and sneezing with spastic paraparesis and sensory loss up to the level of the compression اللي هو لغاية الشست. Typical in the case just as extradural meningioma. يعني هي دي مشخصينها extradural meningioma.
Perfect,
I
Dr.
think it's a
Marwa.
very difficult case, and it's I mean, there is no the exam of the lung is completely normal. So is it coming from lung? Mets from where? Lung is
No,
completely
it's
exam normal.
primary. No, spinal cord tumor.
Extradural
Primary.
tumor.
Meningioma, yes. It's
Meningioma,
meningioma,
yes.
not metastasis.
So extradural meningioma compressing the cord, causing paraparesis, and the radicular pain causing the chest pain.
Yes.
Tamam. Okay.
Yeah, it's a nice case. And very interesting one. Difficult scenario. Dr. Mahmoud reached diagnosis, and we learn a lot from this scenario. All of us thought about paraneoplastic, but it's something primary from the spinal cord itself, which could be meningioma. Again, the B symptoms here will be the clue, right? So the patient will have weight loss and loss of appetite, Dr. Marwa.
No, not have. This meningioma may be benign, not malignant.
Okay.
No B symptoms.
No B symptoms. Okay. But as you said, it's alarming, having alarming sign or red flags in the form of urine incontinence. I guess the patient also will have back passage uncontrolled or difficult to
Not
control.
mental. That is a normal motion.
Not the motion, the control over the back passage.
Control, no change in, no affection
Not
of control.
mentioned. Not
Not
mentioned.
mentioned.
No,
Okay,
it should
we
lose.
can.
If you are saying
Yes,
paraparesis, how come the
I
bladder
agree.
is intact? So
Yeah.
it's not
So
matching the clinical. Tamam, it has to go. If you are
Mm,
yeah,
calling cause compression, so the bladder will not be intact.
exactly. Both
mm,
of
The
them will
body
be
will.
lost.
Yeah.
Yes, I agree with Dr. Rabia. Dr. Rabia, as a neurology, of course, she commented on this point. I guess
mm,
the control over the bladder and the rectum will not be, I mean, either to be lost together or
mm.
can be, Dr. Rabia, to be lost one and the other one will be spared. Is it
Yeah,
possible?
usually bladder is gone first and then the bowel goes. Okay.
Oh, okay.
Maybe
Because
this early بقى early stage.
Okay.
Because in
uh,
scenario يعني it is mentioned that there's no change in control, no effect in control in bowel motion. It's mentioned.
No, yes, yes, it's okay. We are just trying to figure out and to learn what could
Okay,
be
I know.
lost, what could be spared, and that's it. So you
Mm,
can find both, either lost both or one
mm,
spared and other lost. So the bladder will be lost earlier. Okay,
mm.
this is related to the point of incontinence. The other finding here was the weakness, which was upper motor neuron, stiffy one. Again, in the tone, the power reflex all will be high or exaggerated. And
Power decreased.
sorry.
Power decreased.
Yes,
Power.
yes, weakness. Yeah, but I mean
Mm,
the tone, hypertonia, the reflex is exaggerated or
mm.
hyperreflexia. And of course, you have to do clonus, Dr. Mahmoud. Okay.
Yes.
Rombic test here is very important because the patient is having unsteadiness. She said to you many times, I feel, I feel. So you have to analyze. Did you, how many? So are you feeling unbalanced or are you feeling unsteady? You have to ask this question. You suspect cerebellar affection here or dorsal column. And I guess it will be dorsal column in this scenario. And so you have to do Romberg test. Okay. The sensation, of course, you have to do. Definitely, any of the modalities will be lost, either superficial or deep, according to the column affected. Dr. Rabia, agree?
yes, agreed, Dr. Basim, you're right. Mm,
So you have to do full neurological examination. You have a clear,
mm.
clear neurological condition. We suspect also, as some of doctors, Lambert Eaton, I suspect paraneoplastic. Anyway, if you said any of these, you can get a mark because the presentation is vague as well as the complication also is vague. Patient is smoking 40 cigarettes per day with nicotine staining and difficult to find normal chest examination, Dr. Marwa. I'm not sure if they wrote like this or there is something in the chest or
In chest?
there is, yeah,
No,
eh,
nothing in chest.
40 cigarettes for 40 years without any. Okay, we suspected.
She is COPD.
Yes,
Yeah.
so if COPD, at least he will have vesicular breathing, expiratory
Um,
wheezes, right?
I think not
So
mentioned
prolonged,
about. Not
it's
mentioned
okay.
anything.
But since the patient is having nicotine sensing means he's heavy smoker and some change, and that's why Dr. Mahmoud is insisting no bronchial breathing, no bronchial breathing, no vesicular, long prolonged vesicular. But anyway, we are talking together to figure out why and what you could find in this patient. You might have bronchial breathing, you might have lung mass, you might have pleural effusion, you might have COPD finding like prolonged vesicular breathing and wheezy chest, patient on inhalers. As you said, there is steroid, you suspect either weakness or you might even find cushingoid features, fat distribution. So it's really complicated case, and I think it's not coming in this way in cases, but we have to learn how to approach such cases. That's why we always say whenever you did analyze or analysis of the complaint, analyze the red flag of the complaint or the serious form of the complaint. In the previous scenario, Dr. Marwa, you didn't ask about the red flags, which is increased intracerebral pressure, headache with signs of increased air pressure. You have to ask
I
about the
asked
cuff.
asked it.
You ask, okay.
Ask
But
it. Yes, ask it, Dr.
you
Nancy.
ask about the position, the cuff,
Mm,
sneezing, okay. The vision, affection, okay.
yes.
Here in this scenario, what's the alarming or what the red flag here? What are they?
Incompetence.
Incontinence, the
Mm,
weakness, the lumps and
insomnia.
lesions. Even you can say any back pain. Okay. And trauma, very important to ask, and Dr. Mahmoud covered this question. Any trauma, a patient might have trauma to the back, and it will be the reason like disc prolapse. Anyway, this is not the case here.
I think also Bot's disease and TB maybe برضه the cause.
Okay, but again, the B symptoms and signs will be there in the form of loss of weight, loss of appetite,
Mm,
night sweat, night body temperature, or rising body temperature, right? But again, you
and
can ask this question, or if you find positive, you can suspect
mm,
TB spine,
also
which is foot disease.
myasthenia
Yes,
gravis.
myasthenia will be lower motor neuron features. It will
Mm,
not be upper motor.
before examination, yeah, for at
Yes,
history.
he has to ask about timing, any timing
Mm,
change or weakness you notice.
mm,
But I guess it will be negative. So since the question of stiffy or floppy, it's clear upper motor neuron region. I will not ask about myasthenia. I will ask about the stiffy weakness. Let's enumerate them. What do you think, Dr. Mahmoud? Stiffy lower limb weakness. Give me
Stiff,
three reasons. Yes.
stiff lower motor neuron.
No. Stiff lower limb weakness. I mean upper motor
Yes,
neuron lesion.
stiff.
What are they? Okay.
Okay, stiff
Both.
lower
Uh,
motor, maybe hemiplegia, stroke,
okay. Yes.
and according to stroke, trauma, tumor,
Excellent. Okay.
TB,
Excellent. So
disc.
you mentioned the 3T. If you mention the
Yes,
3T, yeah, you got the mark.
yes,
TB,
yes, yes.
trauma, tumor.
Disc.
Okay. What else in basis?
Thinning of the bone, osteoporosis.
Why you went about? Why you thought about this? No, I'm
Okay,
not thinking
this
about
is
in
another.
basis in female, middle-aged female patient.
MS, doctor.
Excellent.
Yes.
Oh yes. So this is also another. You can suspect the other causes of neurology, which are
Transverse myelitis,
okay. This is rare. Or transient
vasculitis,
myelitis. Uh,
post-infection.
okay. There are two combined disease in the same name.
Yes.
What are
Uh,
they? Hereditary and tropical.
yes, it is intact sensation.
No, no, no.
Yes,
Spastic paraparesis. Spastic
yes,
paraparesis.
hereditary specific paraplegia
Hereditary
and
and tropical.
tropical specific paraplegia. Yes, doctor.
Okay.
Mm.
Also meningioma in the brain,
Meningioma.
bilateral meningioma. It can present with this. What else, Dr. Rabi, I want to add? I'm talking about upper motor neuron or stiffy
Mm,
weakness.
yeah, bilateral ACA strokes. Okay,
Yes. Okay.
frontal meningioma.
Yes.
So
Parasagittal
that
meningioma. Okay.
so yeah. Okay, then you can put cerebral palsy can come with stiffness in bilateral lower limbs also.
Exactly, yes. But the patient will be
Yes.
mentally retarded. Yes. What
Yes,
else?
yes, yes, absolutely, absolutely. And then hereditary spastic paraparesis and the same
Yes.
as
The
you
hereditary
discussed.
and the tropical. Yes.
And tropical, yes.
Yes, and I think motor neuron
Yes.
disease also, Dr. Basim.
Motor
Less
disease will
likely to
be
be only lower motor,
yeah.
yes, only lower limbs.
There is a
But could
variant.
be.
I think there is a
Yeah.
variant of
Could
motor
be.
neuron
Could be.
disease.
Yes. Yes. Could be. But it's not common as with what we mentioned. Okay. So you can put it
Mm.
at the bottom. Subacute combined degeneration is very important, and you have to ask about diet history, as Dr. Marwa said also. Okay, what else you want to add in the differential? So I think we covered most of the causes and the differential for this case scenario. You talk long history, Dr. Mahmoud. This is another comment. Long history, and you start examination at the 13 minutes. In the exam, you will lose the mark for examination and the consent. try to finish the history as fast as possible.
Yes, doctor.
By the way, you cover good question for the family history. You ask about any family history of tumor, any family or cancer, sorry, any family history of nerve disease, I think, or stroke.
Yes, early death and stroke.
Okay, why that early death? What you
Uh,
suspect?
Patient is 63, so it is wrong question.
No, no, I
Early,
mean, don't ask question unless it give you a clue.
yes, doctor. Early death in Hocum and polycystic kidney.
So it's not, yeah, doesn't make sense to
Yes.
ask early death here. If you
Yes, doctor.
suspect heart disease, but I said about the question for the nerve and for the cancers because you suspect cancer, stroke, I mean, and cancer. It's important because both of them are differential. Okay.
Yes, doctor. Yes.
Okay. Any other comments? I will ask Dr. Rabia because she's our neurology
No, Dr.
consultant. So
Basim, it's very clear. It's a difficult case, but it's very clear.
yes.
Nothing to add.
Okay. Again, the paraneoplastic and the spinal cord. If you said spinal cord lesion or spinal cord space occupying lesion in the form of whatever, either primary or metastasis, you will suspect cancer by anyway, either
Mhm.
primary or secondary, because he's having a long history of heavy smoking.
Yeah.
Okay.
Sometimes even Dr. Basim, if you have
Mm.
suspecting paraneoplastic, so you will not
Uh-huh.
find the primary malignancy. Okay, for these type of patients, you have to screen them with CT pan, and even if
Mm-hmm.
it's negative, you have to maybe after many years they will become positive. So now they are
Mm-hmm.
doing PET scanning for them. Okay, for the hidden
Mm-hmm.
malignancies.
Uh-huh.
So you have
Okay.
to so sometimes paraneoplastic comes without with the hidden malignancies, and you
Mm-hmm.
cannot find them on the first time. And after repetition, after 1 year, maybe you will find them. Okay, so it's one of the
Okay.
very good differentials: paraneoplastic cerebellar, paraneoplastic spinal, or paraneoplastic sensory neuropathy.
Yes. And you remember the other anti-U and the anti-Ho, other
Yes,
than
yes.
both? What
No, no,
others?
no. Most important is anti-WHO,
Yes.
anti-Rho. These are the main
Yes.
antibodies.
Okay. Yeah. You have to put them in the differential, as Dr. Abia said, since the patient is heavy smoker. Okay. Any other question from Dr. Mahmoud, Dr. Marwa? Any other comment? Dr. Mahmoud, Dr. Marwa?
No,
Yes.
I don't.
Thank you, Dr. Marwa. Thank you, Dr. Basim. Thank you, Dr. Rabia.
Yes.
Thank you very much.
Nice. Nice. Both
Nice.
cases are nice, really. Okay, let's go to the comment. And anyone want to comment, please feel free to comment. Dr. Hanna, I think still as yesterday, driving the same
No,
time.
no, I just arrived,
Okay,
working for a couple of days.
comment on
Uh,
your friend. Yes.
so my friend is always my friend, Mahmoud. Um,
Thank you, Dr. Man.
but anyway, I feel the second scenario is is very difficult to appear in bases. I think the exam is easier easier than this kind of cases.
Yeah, it will be clear. They are not,
Yeah,
but in UK, they are giving these scenarios, and it
I
will be difficult.
I said for the exam. The exam in UK is much easier than in Egypt.
No, don't say
No,
that,
the exam is
please.
very easy. I didn't pass because I'm not ready. Actually, I was applying
Okay.
like, but I
Yeah,
don't know
I will try
anything.
only. Yeah, I will
Yeah,
try.
just mock
Yeah.
test. But the exam in UK was very easy, comparable what we are discussing in this group. So if you could diagnose this case, I think you will pass base. Some cases is difficult in base like Frederick ataxia. I noticed some comments. So Frederick ataxia is very difficult to get an exam. But I think upper motor with peripheral neuropathy uh,
With
with cerebellar
ataxia.
symptoms
Yes.
bilateral, it will guide you.
With diabetes, with peripheral
Diabetes.
neuropathy.
So it's this is the most difficult case in base is Frederick
What
attacks.
Frederick ataxia? No, I'm against in this point because it's a complex of, as you said, cerebellar, peripheral neuropathy, and ataxia,
Yeah, yeah.
and
If you are not expecting
hammer
Frederick
two. Yes,
attacks in
if you did
exam,
it, yeah, if you did it once, you will not forget it. But
Yeah,
if
yeah.
you,
If you are not predicting, I was not
yes,
predicting
yes,
Frederick ataxia, so I couldn't correlate the signs with each other. So
okay,
what is the
yeah,
cerebellum and peripheral neuropathy is, and why
and
upper
diabetes.
motor neuron?
Uh-huh.
So
You're right. It's difficult, but it will be in young patients. Tell
young
me he
patient,
was young, right?
young, and
And
frankly
family history,
ataxia. So this
ataxia.
ataxic syndrome, enough to say inherited ataxia or acquired ataxia, and it is the types of acquired and the types of congenital ataxia. I think, yeah,
Yes,
from my experience, the exam is easier than this.
yes, you're right.
But anyways, this is very good chance to practice the approach.
Yes. So
Uh,
let's mention now the causes of ataxia in exam, in basis, and in young as well. What do you think? On the top, of course, Friedreich ataxia.
Inherited, we will divide it: inherited and
Yes,
acquired. Inherited
exactly,
Friedrich ataxia, and I don't
exactly.
know any other kind.
Why
Uh,
vitamins? Vitamin subacute combined degeneration. It's very important differential and drug induced.
no, it will come under acquired. So
Yes, I
acquired
know.
can be
Okay, you mean about
cerebellar,
okay the
cerebellar,
other
sensory.
congenital?
This is inherited.
Okay,
Um,
inherited. There is another inherited, which is called
I don't know.
spinothalamic ataxia. Dr. Rabia, spinothalamic ataxia. Dr. Rabia,
Spinocerebellar ataxias.
yeah, spinocerebellar ataxia. This is
Yeah.
the other form of inherited ataxia. So
Mm,
Yes,
Friedreich
absolutely.
ataxia,
Yeah.
spinocerebellar ataxia. Yeah, it's one
Yes.
of
good.
the yeah, and with family history as well.
Okay, acquired will be
Okay,
idiopathic,
yes,
Alcohol,
sensory,
exactly.
alcohol.
cerebellar, vestibular.
Yes, and don't miss the subacute combined degeneration. Drug induced, anti-epileptic, the phenytoin. Okay.
It comes under sensory ataxia. So sensory ataxia means loss of deep sensations. It could be peripheral neuropathy by all causes.
Yes,
So when I say cerebellar ataxia means MS in cerebellum, alcoholic,
excellent.
yes, vitamin
Yes,
B12
yes,
deficiency. When I say
perfect.
sensory ataxia means peripheral neuropathy, whatever the
Yes,
reason, uremia,
yes,
diabetes, alcohol, vitamin B12, immune
excellent.
mediated,
HIV.
HIV,
Yes,
Lyme disease, whatever, uremia,
yes, you're right. Yes,
whatever
you're
the
right.
case. So
Yes,
sensory ataxia is I think is
much
inclusive
common.
inclusive term to underlying peripheral neuropathy.
Yes, yes, you're right. And Friedreich ataxia will be either sensory or cerebellar in both. It's combined.
Yeah, so you find cerebellar signs, you will find peripheral neuropathy and upgoing plantar.
Yes, exactly. And sometimes mute. You can find mute as well. It's possible to find both.
Mute. Okay,
Yeah.
but the clue is the upper motor neuron.
Yes,
So
and cerebellar.
and cerebellar. So upgoing plantar is the most specific test for upper motor and lower limbs.
Okay. I will ask you now. Did you find hammer two or Biscavus? It was there because it's also
It's difficult
pathognomonic.
difficult to remember. Difficult to remember. Um,
Yes, you're right. If you
okay.
didn't catch the diagnosis, you will never remember what
No. If
happened
you
there.
couldn't think, you will not search for. If your mind is not
Yes, yes,
focusing
yes,
how to see, you will not see.
yes, you're
So
right. Okay, so the take-home message from your case and your experience, I will add the ataxia cause and basis. It will be the message today, along with Dr. Marwa scenario, the space occupied lesion or spinal lesion.
ممكن
You
add
can,
spastic paralysis.
yes, okay, yes, you're right. Spastic paraparesis, because it was the case. Spastic paraparesis and Dr. Mahanna case, ataxia and basis, either cerebellar or sensory. Okay. Any suggestion from others? Any comment from others, Dr. Ayan? Thank you, Dr. Mahanna, again for your practice and experience. Hopefully, you will practice with us one day.
tomorrow, if the slot is
Friday,
ready, tomorrow.
I'm
بس.
for. Unfortunately, Friday I we take off just to.
Saturday.
Okay,
Saturday.
Saturday. Okay, I will give you Saturday. I
I
might
say,
do with you also.
okay. Okay.
Okay,
Good.
and thank you, Dr. Manna. Again, anyone else? I guess Dr. Muhammad. You want to add comment, Dr. Muhammad Mustafa? You are mute. You are unmute. I don't know. You unmute yourself or by mistake. I will call Dr. Ayan if she's still there or she left. Okay. Anyone else want to comment? Muhammad, are you saying something? We can't hear you if you are. Frederick attack cervical myelopathy in the comment. Dr. Ahmed, cervical myelopathy, but patient has no weight loss and anorexia or fever. Yes, I guess it will be a clue for the multiple myeloma. Yes, of course. Plus anemia. Don't miss the anemia. Crab. You will find. You have to find four components of crab: hypercalcemia signs and symptoms, and uh, anemia, crab, and bone lesion. And the R was, who remember the R? Crab. I think renal failure. Yes, I got it. Okay. Address concern by yes or no. You didn't address the concern. Thank you, Dr. Hadil. You have to yes or no, Dr. Mahmoud. Whenever there is concern, do I have cancer? You have to address it. Either yes or no, high possibility or low. Don't skip. Okay, this is one the point you will be judged on the concern. You have to address the concern clear. Do I have a cancer, doctor? Unfortunately, I am afraid to say either high possibility or low according to your suspicion. So in this scenario, you say, I'm afraid to say, and I'm so sorry to say, you might have a cancer. Okay, it's
Dr.
one of
Basim.
our possibility. Yes, it's who? Yes, Dr. Muhammad, you are talking. So you can say again, your voice is lost, Dr. Muhammad. Please check your mic. So you can say, Dr. Mahmoud, I'm afraid to say yes. Cancer, one of our possibility. We have to admit you to run some blood tests and scans to confirm if you have or to confirm if you don't have. But it's one of our list, or you can say even in the top of our list. Okay, in this scenario specifically.
Okay, Dr. Basim.
Yes, you can talk now. We can hear.
No, I am Mahmoud, Dr. Basim, not Dr. Muhammad.
Okay, okay, Dr. Mahmoud.
Oh, cool.
You heard the comment, right? Okay.
Yes, thank you.
So don't skip. Don't.
But
I mean, don't hide what you want to say.
yes, the problem here, Dr. Basim, it is no lose weight. So I don't
Still,
know.
you have other risk. You have other risk,
Yes,
which is smoking.
smoking. Yes.
And you said there is possibility of compression by lesion.
Mhm.
So what could be the lesion? Either TB or trauma, and already denied the trauma. So might be space occupying lesion. By the way, in this scenario, the cancer itself as a cancer, it might be either benign or malignant. So you can say overgrowth,
Mhm.
okay?
Okay, Dr.
Lesion due
Basim.
to overgrowth. But
Okay.
you have to, I mean, you have to answer here clearly. Don't say, we have to do some blood test and
Mm.
without saying it's one of the possibility. You have to say it, okay?
Mhm. Okay, Dr. Basim.
Clearly. Okay,
Okay.
thank you, Dr.
Thank you.
Mahmoud. Thank
Thank you
you.
very much.
Most welcome, Dr. Mahmoud. Thank you, Dr. Mahanna, Dr. Rabia, Dr. Marwa. All of you are great. Before enjoying the weekend, we'll wish you all the best. See you, inshallah, after the weekend.
It's the
Good
most
luck and
worst. It is the worst moment in the meeting, Dr. Basim. When you tell end the
it's
meeting.
Alhamdulillah, it's daily basis. We are hearing each other every day, apart from the Friday. So it's okay.
Okay,
Better
Dr.
than
Basim.
alternating sessions. It's one
Yes. Sure, Dr.
daily,
Basim. Yes.
once daily. Yeah. So it's at least we are meeting every day. Thank you, Dr. Mahmoud, for your words. Always appreciating. We'll see you,
Thank you.
inshallah, after tomorrow. Enjoy your weekend. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.